Welcome to the deep dive. Today we are undertaking, well, a truly intensive mission, achieving an elite-level mastery of the knee joint surgical anatomy. We have before us a highly technical stack of sources, really the essential playbook for any professional orthopedic specialist, and our goal is to unpack every single structural relationship. We want to move far beyond basic memorization into the critical nuances of this immensely complex joint.
Exactly. This deep dive is absolutely about translating that anatomical knowledge into clinical strategy. We are not just listing parts here, we are synthesizing the relationships. Understanding what overlays what, which rotational stability mechanism relies on which specific insertion point, and critically identifying the exact neurovascular pathways that, well, they demand protection during open or arthroscopic exposure. We'll blend embryology, surface landmarks, and the complex soft tissue layers to provide you with, hopefully, a comprehensive professional roadmap.
Yeah, and our mission is exhaustive, isn't it? We are starting right at the beginning with the microscopic blueprint of its development, detailing how the knee cavity officially forms at stage 22, that's about 52 days post-fertilization, and will progress right through the intricacies of the collateral and cruciate ligaments, ultimately culminating in a detailed analysis of the critical anatomical hazards inherent in all common surgical approaches.
And that surgical application, that's precisely the reason for this level of detail. This knowledge is absolutely foundational for several high-stakes procedures. Now, while the most common large procedure is joint arthroplasty, or total knee replacement, it is equally vital for open and arthroscopic anterior cruciate ligament, or ACL, and posterior cruciate ligament, PCL, reconstruction. We also rely on this detailed map for meniscectomy, joint washout when treating infections, and the complex fixation of distal femoral or tibial plateau fractures. Every single layer we discuss is a potential layer of incision or, potential hazard.
Okay, let's unpack this right from the beginning then. To understand failure modes or congenital variants, we really need to know the construction timeline. For a joint that bears so much weight and handles such complex motion, the speed at which it develops is, well, truly surprising.
It is remarkably fast.
Yeah.
The development of the knee isn't just one single event, but a precise chronological sequence of condensation and differentiation. The process begins quite early with chondrification, that's the formation of cartilage, in the femur, tibia, and fibula by stage 18. This occurs roughly 42 to 44 days post-fertilization. So this initial stage establishes the future-long axis of the bones.
Okay, stage 18. And when do the shapes that we actually recognize, like the femoral and tibial condyles, become structurally defined?
Right. Those recognizable structures, the condyles, along with a distinct mesenchymal patella, so not cartilage yet, become clearly distinguishable shortly thereafter. That spans stages 19 to 20, which is approximately 45 to 50 days post-fertilization. The basic geometry of the joint is pretty much locked in at this point, but structurally it's still, a relatively solid mass of cells.
So we've got the bony outlines, but the joint needs space, it needs to move. When does the synovial environment, the actual knee cavity, appear?
Ah, good point. The actual knee joint cavity appears later. That happens during stage 22, spanning 52 to 55 days post-fertilization. And this cavity formation begins initially as the femoropatellar joint, starting kind of from the periphery of the articular inner zone. This delayed hollowing out of the joint capsule after the basic shapes are formed is really crucial to its mechanical integrity later on.
What about the intra-articular buffers, the menisci? When do they transition from just undifferentiated tissue into those C-shaped structures we recognize?
The menisci develop from the eccentric portions of that original articular inner zone during stage 22, so the same time the cavity is forming. However, they aren't fully distinct or easily distinguishable structures until after stage 23, which takes us up to maybe 53 to 58 days. And we should also note the chondrification of the patella itself, the process of turning that mesenchymal structure into actual cartilage, only commences during stages 21 to 22. This incredibly short, intense window of cellular organization is why congenital joint issues, though rare, tend to be quite profound when they do occur.
Right. Given that everything is condensing so rapidly, what's the chronological hierarchy of the major stabilizers? Which ligaments get laid down first?
Well, the condensation of the connective tissues follows a very specific and quite telling sequence. The patellar ligament is established first. It condenses during stages 18 to 19. This really emphasizes the early evolutionary and developmental importance of the extensor mechanism.
Okay, patellar ligament first. What follows the extensor mechanism?
Immediately following, in stage 19, we see the condensation of the major lateral stabilizer, the fibular collateral ligament, FCL. And this happens alongside the tendon of popliteus. So establishing lateral stability seems to be the next priority. Then in the combined window of stages 19 to 20, we see the condensation of the patellar retinacula and, critically, the cruciate ligaments, the ACL and PCL.
That suggests the core rotational stabilizers, the cruciates, form pretty much simultaneously with the mechanism that holds the patella in place.
Precisely, yeah. It's only in stage 20 that the tibial collateral ligament, TCL, the main medial stabilizer, and the main bulk of the menisci begin their full condensation sequence. The fact that the XCL starts condensing before the TCL gives a really fascinating glimpse into the mechanics of early stability. It's quite interesting. And finally, the more superficial structures, the oblique popliteal ligament and the overall articular capsule, they're the last major components to fully condense, completing the joint around stage 23. This early developmental sequence really underscores why, structurally, the knee relies so heavily on the integrity of the extensor mechanism and those lateral stabilizers.
Okay, let's shift from the microscopic blueprint now to the living patient, the surface anatomy. Well, that's the orthopedic professional's initial map, isn't it? It guides the placement of skin incisions and determines the safe paths. How do we start mapping the joint just by observation and touch?
Right. Well, first, we must differentiate between structures that are always palpable and those that are only visible depending on the patient's physique and, muscle definition. When the patient is relaxed, we look at the asymmetry.
Okay, let's focus on the distinct boundaries created by the surrounding musculature. What do we see?
Okay, on the medial side, the vastus medialis forms a very recognizable soft bulge that sits supraremedial to the patella. You can usually see that. Inferiorly, the flat subcutaneous surface of the tibia is continuous with the medial condyle, providing a large, stable, bony area that you can feel easily. Conversely, the lateral side is dominated by dense, fibrous tissue. The aponeurosis of vastus lateralis and the exceptionally strong tensioned band of the iliotibial tract, they form a firm, flat surface superior and lateral to the patella. The anterior edge of that iliotibial tract creates a visible, straight line lateral to the patella that is really key to finding the interval for surgical approaches.
And the central stabilizing structure.
Right down the middle, yeah. The patellar ligament extends visibly and palpably from the apex of the patella down to its insertion on the tibial tuberosity. Its continuity is the foundation of the entire extensor mechanism. You can feel that very clearly.
Now, for surgical planning, what are the 3 or 4 absolutely non-negotiable bony landmarks we must confirm by palpation before we even think about scrubbing in?
Okay, number 1, confirm the mobility and integrity of the patella. You can palpate its entire circumference, except of course for its posterior articular surface. Then, for defining the proximal limit of a medial incision, the adductor tubercle is essential. You find it high up on the superior edge of the medial condyle of the femur, sort of nestled in that soft interval between vastus medialis and the hamstring insertion point. It acts as an excellent superior marker.
Got it. And the corresponding lateral marker for the distal attachment of the iliotibial tract.
That is Gerdy's tubercle, the insertion point of the iliotibial tract. It's located on the anterior aspect of the lateral condyle of the tibia. You find it roughly midway, both longitudinally and transversely, between the apex of the patella and the head of the fibula. Confirming its exact location is absolutely essential for any lateral approach or for assessing iliotibial band pathology.
You mentioned the soft spot, the primary entry point for arthroscopy. Let's provide a clearer 3D definition of that critical triangular space.
Yeah, the soft spot, it defines the optimal location for portal placement. It's a triangular region, clearly bound by 3 structures, inferiorly by the patellar ligament, superiorly by the condyle of the femur, and posteriorly by the joint line. The reason it is a soft spot is because the joint capsule here is remarkably thin and superficial. It provides the most direct, least invasive access point for the arthroscope and instruments into the suprapatellar pouch and the main joint space.
Okay, crucial landmark. Finally, we must map the neurovascular structures that lurk just under the skin. What do we need to be aware of?
Right. Starting medially, we have a significant structure to protect the saphenous nerve. This nerve becomes superficial distal to the adductor hiatus and runs in very close proximity with the long saphenous vein, a key marker here. The vein ascends roughly a hand's breadth posterior to the medial border of the patella. Any medial dissection must anticipate these structures to prevent, potentially debilitating nerve injury or uncontrolled venous bleeding.
And the deep critical structures that supply the lower leg found anterolaterally?
The major arteries and nerves supplying the anterior compartment, that's the anterior tibial artery and the deep fibular nerve, they start their descent deep within the musculature at a precise surface point. That point is midway between the tibial tuberosity and the head of the fibula. Knowing this starting point helps a surgeon anticipate the depth and location of these vital vessels as they continue distally down the leg. Now, to approach the knee surgically without causing iatrogenic injury, one must understand the knee not just as a single joint, but as a series of integrated fascial layers. We typically conceptualize 3 layers around the knee. They are most distinctly separated laterally, but they tend to blend toward the midline medially.
Okay, 3 layers. Let's start with the largest envelope, layer 1. What does that encompass?
Layer 1 is the outer investing fascia. It's continuous with the fascia lata coming down from the thigh. It acts as a continuous sheath, really defining the boundaries of the musculature. It encloses the sartorius muscle medially and the biceps femoris muscle posterolaterally. When a surgeon makes a skin incision, they are cutting through this primary layer first.
And the iliotibial tract, that massive lateral stabilizing structure, is an integral part of layer 1, correct?
Absolutely. The iliotibial tract, or IT band, is the vastly thickened, exceptionally strong lateral component of layer 1. It's securely attached to Gerdy's tubercle, as we just discussed. Posteriorly, this layer continues, covering the gastrocnemius muscle and becoming continuous with the popliteal fascia in the back of the knee. Understanding this tension structure is key. Incisions often have to be made parallel or adjacent to the IT band to preserve its function.
All right, moving deeper then to layer 2. This houses the main collateral ligaments, so this middle layer is where the passive stability is really concentrated.
Precisely. Layer 2 is the collateral and patellofemoral ligament layer. Let's focus on the distinction between the 2 collateral ligaments because their relationship with the capsule dictates surgical approach and, importantly, injury patterns. The tibiocollateral ligament, DCL, or the medial ligament, has a superficial part with both vertical and oblique fibers. It attaches proximally to the medial femoral epicondyle, but its distal attachment is quite broad, inserting maybe 6 to 7 centimeters below the joint line, and it's situated posterior to the pes and serenus tendons.
And how does that differ structurally from the fibular collateral ligament, the FCL, on the lateral side?
Well, the fibular collateral ligament, FCL, the lateral stabilizer, is characteristically cord-like and distinct. It's much more defined. It runs from the lateral femoral epicondyle down to the head of the fibula. The critical distinction here is that the FCL is separated from the joint capsule by a bursa. This anatomical separation means that a tear of the FCL is often an isolated ligament injury, whereas a tear of the medial TCL almost always involves deeper structures due to its intimate capsular connections. That's a key difference.
And regarding their function during motion, how do they behave?
Both ligaments function as taut restraints, primarily in full knee extension. That's when they maximize stability. When the knee is locked out straight, they begin to relax progressively as the knee flexes.
Okay. Layer 2 is also reinforced posteriorly, you mentioned. Can you describe the structures derived from the semimembranosus tendon expansion that stabilize those posteromedial and posterolateral corners?
Yes, that expansion of the semimembranosus tendon is crucial back there. It forms the oblique popliteal ligament, which sweeps superiorly and laterally across the posterior joint capsule, heading toward the lateral femoral condyle. It provides excellent posterior capsular reinforcement. The other structure derived from it is the arcuate popliteal ligament. This ligament attaches to the fibula head and spans supromedially, crucially passing over the tendon popliteus. These structures blend pretty seamlessly with the posterior joint capsule, making the back of the knee very strong indeed.
We should probably briefly address the controversies surrounding the anterolateral ligament, the AL. Is it a true distinct structure or just thickening of the capsule? What's the current thinking?
Yeah, the debate definitely continues on that one. It has been described as a distinct structure attaching to the posterior-superior aspect of the lateral femoral epicondyle and running toward the lateral tibial plateau. However, many established anatomists argue that it's simply a capsular thickening or maybe a component of the broader lateral joint complex, perhaps even a deep, bifurcated part of the FCL itself. Clinically, it's relevant because rotational knee instability is often attributed to this specific area, whether you call it a distinct ligament or a capsular complex. The function is debated, but the location is important.
Understood. Now let's dive down to layer 3, the deepest structure, the joint capsule itself.
Right, layer 3 is the capsule proper. It's composed of the superficial fibrous layer and the deep synovial membrane lining the joint. Structurally, it's incomplete anteriorly, where it seamlessly merges with the quadriceps tendon, the patella itself, and the patellar ligament. But basically, the entire extensor mechanism is the anterior capsule. It is also incomplete posterolaterally. It specifically contains an opening or hiatus to allow the popliteus tendon to exit the joint behind the lateral tibial condyle.
And this layer, layer 3, is where the clinical importance of the medial collateral ligament truly manifests, isn't it?
Absolutely. The fibrous capsule is significantly thickened medially, and these vertically orientated fibers actually constitute the deep medial part of the tibio-collateral ligament. This deep layer is distinct from the superficial layer we discussed in layer 2. Crucially, the deep TCL attaches directly to the tibia at the level of the meniscus. This direct, intimate attachment is the fundamental anatomical reason why a severe valgus force causing a TCL tear almost always involves the medial meniscus as well. This results in that classic unhappy triad injury pattern: TCL, medial meniscus, and often ACL too.
Okay, that connection is vital. Finally, let's expand on the vascular supply. The anterior knee is a highly active surgical site, yet the blood supply must be protected. How does that work?
Well, the skin and capsule over the anterior knee are maintained by an astonishingly rich arterial network. It's known as the genicular anastomosis. This multi-source supply provides excellent collateral flow, which is good news for healing. The primary contributors are the 4 or 5 genicular branches of the popliteal artery, especially the medial genicular ones. Along with those, you have the recurrent tibial and circumflex fibular branches coming up from the posterior tibial artery, and the descending genicular branch of the femoral artery, which travels alongside the saphenous nerve, a real network.
So what does that extensive anastomosis mean for a surgeon planning an incision? Does it make things safer?
It implies a degree of safety, yes, provided you stick to certain anatomical zones. Since the blood supply relies on arteries spiraling around the joint and perforating through the intermuscular septa, incisions placed along defined intermuscular planes, like the standard medial parapatellar or lateral approach intervals, are less likely to disrupt the primary cutaneous vascular supply needed for good wound healing. Conversely, deep dissection must always anticipate the inferior genicular vessels. They are particularly spiral and tortuous and easily damaged if you're not careful.
Okay, we've established the external architecture pretty well. Let's move inside the joint now to examine the internal components that govern joint motion and stability, starting with the patellofemoral system. The patella, as we know, is the largest sesamoid bone, acting as a fulcrum for the quadriceps muscle.
It is indeed the most impressive sesamoid bone, completely contained within the quadriceps tendon. Its articular surface, the part that glides against the trochleus of the femur, is quite asymmetrical. It's divided by a vertical longitudinal ridge, but the lateral facet is consistently larger than the medial facet. And that's an important consideration when you're assessing patellar tracking and the risk of dislocation. That asymmetry matters.
What provides the main passive restraint to stop the patella sliding sideways, laterally?
That passive stability is primarily handled by the medial and lateral patellar retinacula. These are essentially the aponeurotic extensions of the vasti muscles that reinforce the joint capsule on either side. But the real heavy lifting for medial stability, preventing lateral patellar dislocation, is done by the medial patellofemoral ligament, or MPFL. This structure is generally broader and more consistently found than the lateral ligament, confirming its essential role as the principal passive medial stabilizer.
And the articularis genus, that small, often forgotten muscle deep to the quads, what is its specific function? Why is it there?
The small articularis genus. It's actually derived from the deep fibers of the vastus intermedius muscle. It inserts onto the synovial membrane of the anterior joint capsule superiorly. Its precise mechanical role is to elevate the synovial membrane superiorly when the knee moves into full extension. Basically, it prevents the capsule or the synovial lining from getting entrapped or pinched between the advancing femur and the patella. It's a neat little preventative mechanism.
Very neat. Now, for the core engines of stability, the cruciate ligaments, we often forget the anatomical rule for their nomenclature, how they're named.
Yes, so the rule is key and often confused. The cruciate ligaments are named with reference to their tibial attachment site, not where they attach up on the femur. Anterior tibial attachment for ACL, posterior for PCL.
Okay, tibial attachment, starting with the anterior cruciate ligament, or ACL. Trace its path and define its primary role.
Right, the ACL. It originates from the anterior intercondylar area of the tibia, specifically quite close to the insertion of the anterior horn of the lateral meniscus. That's an important relationship. It courses superiorly, posteriorly, and laterally, attaching up onto the posteromedial surface of the lateral femoral condyle inside the notch. Its structure, composed of multiple bundles that tighten in different degrees of flexion, makes it the primary restraint to anterior tibial translation. It stops the tibia sliding forward on the femur.
Okay. Contrast that now with the posterior cruciate ligament, the PCL. How does it differ?
The PCL is substantially different. It's thicker and significantly stronger than the ACL, much more robust. It runs from the posterior surface of the proximal tibia, traversing superiorly, anteriorly, and medially, and attaches to the extensive attachment area on the lateral surface of the medial femoral condyle, so it crosses the ACL. It is the primary restraint to posterior tibial translation, stopping the tibia sliding backwards. The multiple bundles within both cruciates ensure that stability is maintained across the entire range of motion as different bundles become taut during extension versus flexion.
Now, a critical piece of anatomical trivia, but clinically relevant, are the cruciates truly inside the joint space, bathed in synovial fluid?
No, and this is a really high-yield concept. They are extrasynovial. They reside within the fibrous joint capsule, yes, but they are external to the synovial membrane itself. The synovial membrane actually folds around them, almost like they are tucked into a fold of clothing, separating them from the main joint fluid. This is important for understanding surgical repair, healing potential, and even how joint fluid behaves after an injury. Furthermore, they are richly innervated, meaning they contribute significantly to proprioception, the body's sense of joint position. They're not just ropes.
Regarding nourishment, where does the blood supply for these critical, highly stressed structures primarily come from?
Good question. The majority of the blood supply for both the cruciates is carried by the middle genicular artery. This artery penetrates the posterior capsule, often near the posterolateral corner of the intercondylar fossa, and forms a vascular network in the surrounding synovial tissue that covers the ligaments. Supplementary blood comes from the inferior genicular vessels supplying the tibial attachments, especially near the bone. Importantly, though, the fibrocartilaginous zones of the ACL near its insertions and the central posterior third of the PCL are relatively avascular. This makes healing following mid-substance tears very difficult without intervention.
Supporting the PCL are the meniscofemoral ligaments, the MFLs. Where are these located and what is their role exactly?
Yes, these are frequently tested minor stabilizers, often seen on MRI. We have the anterior meniscofemoral ligament, AMFL, or the ligament of Humphrey, which runs anterior to the PCL, and the posterior meniscofemoral ligament, PMFL, or the ligament of Risberg, which runs posterior to the PCL. Both ligaments extend from the posterior horn of the lateral meniscus and attach up to the lateral surface of the medial femoral condyle near the PCL attachment. They essentially act as secondary restraints to posterior tibial translation, basically pulling the lateral meniscus along with the PCL during movement.
Okay, now for the menisci themselves. Their shape dictates their mobility and also their vulnerability to injury. How do the medial and lateral menisci compare in shape and attachment?
Right. The medial meniscus is classically C-shaped and notoriously less mobile. This relative lack of mobility stems from its strong, direct attachments. It's firmly anchored medially to the joint capsule and, crucially, as we mentioned, to the undersurface of the deep part of the tibial collateral ligament. It's really tied down. In contrast, the lateral meniscus is much more rounded, approaching a circular or O shape, and is significantly more mobile. Its increased mobility is afforded because it is not attached to the joint capsule laterally or to the fibular collateral ligament. It has more freedom to move.
So how are they held down onto the tibial plateau then if the lateral one isn't attached laterally?
They are stabilized primarily by the meniscotibial or coronary ligaments. These are short fibrous attachments connecting the periphery of the menisci to the edge of the tibial plateau and the capsule. Additional stabilization comes from the transverse ligament of the knee, which connects the anterior horns of the two menisci together, and also those meniscofemoral ligaments we just detailed, which anchor the posterior horn of the lateral meniscus.
Okay, this brings us to the core clinical detail regarding repair potential, vascularity and innervation. Why do central meniscal tears heal so poorly, pathologically speaking?
This is absolutely fundamental knowledge for anyone treating knee injuries. In a mature adult, only the outer 10 to 30% of the peripheral zone of the menisci, what we call the red zone, retains a significant vascular supply from the capsular vessels. The central inner parts, the white zone, are entirely avascular. Consequently, central tears rely solely on diffusion from the synovial fluid for nourishment and, lacking a direct blood supply, possess minimal intrinsic capacity for healing. This biological limitation is the primary driver for surgical intervention, which is typically meniscectomy or removal of the torn part in those central avascular tears.
But the menisci are clearly far more than just passive shock absorbers. They have a sophisticated sensory role, confirmed by their innervation patterns.
That's a critical insight, yes. The meniscal horns, particularly the anterior and posterior horns, are richly innervated. Specifically, they contain spectralized nerve endings called mechanoreceptors. These include structures like Pacinian corpuscles and Golgi tendon organs. These mechanoreceptors are essential for conveying afferent feedback sensory information about joint position, loading, and motion back to the central nervous system. This confirms that the menisci are active participants in sensory feedback and neuromuscular control of the knee, not just passive mechanical spacers.
Right. To complete the posterolateral picture, let's revisit the precise, somewhat complex path of the popliteus tendon. It's the key rotational stabilizer of that corner, isn't it?
It is, and its path is often misunderstood but vital. The popliteus muscle functions as the primary internal rotator of the tibia on the femur and acts to unlock the knee from full extension. Its tendon runs deep within the posterolateral corner. It passes deep to the joint capsule and deep to the arcuate popliteal ligament. Its intra-articular path sees it run superficial to the lateral meniscus, but deep to the fibular collateral ligament. That relationship is key. It then exits the joint capsule through a specific hiatus, or opening, in the lateral mesocutibial ligament, the coronary ligament. This unique path allows the popliteus to dynamically stabilize the posterolateral corner and also protect the lateral meniscus during rotational movements. Okay, so a skilled professional must always account for anatomical variance and also how the knee changes over a lifespan. Anatomy is rarely exactly the same between two patients, and it certainly changes dramatically between childhood and adulthood.
Right. Starting with defined anatomical variance, what key structural differences typically define the female knee, particularly those that influence biomechanics and injury risk?
Well, structurally, the anterior femoral condyles in females are generally less prominent relative to the trochlear groove compared to males. But perhaps more importantly, females typically exhibit an increased Q angle. This angle, which is measured from the anterior superior iliac spine down through the center of the patella to the tibial tuberosity, is wider, generally due to the wider female pelvis. This increased Q angle imposes greater valgus or knock-kneed stress on the knee and is considered a significant risk factor for lateral patellar subluxation and various patellofemoral pain syndromes.
Interesting. What about the most common congenital abnormalities of the intra-articular structures? What variants do we see most often?
By far the most prevalent meniscal anomaly is an enlarged discoid meniscus. This variation, where the meniscus is solid and disc-shaped rather than the normal C or O shape, is almost exclusively found in the lateral meniscus. It's found predominantly in females, often with maybe a 2-to-1 ratio over males, and it can be associated with snapping, clicking, or even locking symptoms if it tears. We also frequently encounter patellar variants.
Regarding the patella, what common anomaly must clinicians be careful not to confuse with an acute injury, especially on X-ray?
Right. The patella develops from multiple ossification centers during childhood. If these centers fail to fuse completely by skeletal maturity, the patient presents with what's called a bipartite or tripartite patella. This usually occurs at the superior lateral pole, is typically bilateral, present in both knees, and is a vital anatomical variant that orthopedic surgeons must recognize on X-ray to prevent mistaking it for an acute traumatic fracture. The edges are usually smooth, unlike a sharp fracture line. Rarer variations include complete aplasia, absence, or a doubled patellar tendon, but the bipartite patella is the really high-yield distinction to know.
Now, connecting this to the bigger picture of pediatric trauma, why is the pediatric knee often described as ligament sparing in terms of how it gets injured? What fails first?
The difference is the inherent weakness of the open physis, or growth plate, in children. The unossified cartilage and developing bone of the growth plate are significantly less structurally robust than the mature ligaments and tendons attached to them. Consequently, under significant stress, the physis becomes the anatomical weak point. It fails before the ligament does. Therefore, the most common type of fracture in this region is the Salter-Harris type 2 fracture, which involves a fracture line running along the growth plate and then exiting up through the metaphysis, the shaft side.
And how does that specifically affect the ACL in children? Do they tear their cruciates less often than adults?
Generally, yes, because the ligament itself is stronger than its bony insertion point onto the immature tibial spine. Instead of a mid-substance ACL tear, which is common in adults, overstressing the ACL in a child is much more likely to result in an avulsion fracture of the intercondylar tubercle, or tibial spine. Essentially, the ligament pulls off a piece of the bone it's attached to. Recognizing this mechanism of injury is critical because surgical fixation of the bone fragment is entirely different from reconstructing the ligament itself.
Given that risk profile in children, how does a surgeon assess for a potential patellar injury in very young children, say under 3, when standard imaging like X-rays might be inconclusive?
Yes, this is a classic clinical workflow problem. The patella is entirely cartilaginous, basically invisible soft tissue, for children under the age of 3. It's therefore completely radiolucent. It just doesn't show up on standard plain X-rays. Ossification only begins between 3 and 6 years of age. So if a toddler presents with knee pain and swelling, suggesting potential patellar trauma, the surgeon must maintain a very high index of suspicion. They might need to rely on clinical exam, possibly ultrasound, or even an MRI in some cases, rather than dismissing the injury based on a negative X-ray alone. You can't rule it out just with X-ray.
Okay, we've covered the layers, the landmarks, the variations. Understanding all this detailed anatomy directly translates into surgical safety and planning. Let's look at the workhorse approaches now, and most critically, the structures that are at the absolute highest risk during exposure.
Right. When planning open surgery, the standard anterior longitudinal skin incision is the usual starting point. From there, the medial parapatellar approach is overwhelmingly the most common approach for major knee surgery, primarily for total joint arthroplasty, or knee replacement. It involved that anterior midline skin incision, followed by a capsular incision made right along the medial border of the patella and patellar tendon.
When extending that incision proximally up into the thigh to gain better exposure for the femur, how far can a surgeon safely go without risking motor function to the quadriceps?
Generally, safe proximal extension covering the distal third of the thigh is permissible. This is because the motor branches of the femoral nerve that supply the vasti muscles are typically given off higher up in the thigh, more proximally. Since the incision runs along the muscle belly, not deep into the main neurovascular bundle in the thigh, the risk to the extensor mechanism's motor function is lower than if one were to, say, cut horizontally across the quad muscle.
But even in this very standard, seemingly safe approach, there is one almost guaranteed neurovascular hazard that requires careful patient counseling beforehand. What is that?
Yes, the most common and often unavoidable hazard of the standard medial parapatellar incision is the division of the infrapatellar branch of the saphenous nerve. This is a purely sensory nerve that crosses the operative field, usually right where the incision needs to go, and it must frequently be cut to gain adequate exposure. This division results in a predictable area of hyposthesia or numbness, classically just lateral to the scar. The surgeon must anticipate this outcome, counsel the patient preoperatively, and frame it as a predictable, acceptable trade-off for the main procedure, rather than presenting it as an unexpected complication later.
Right, managing expectations.
Yeah.
Now, for less invasive procedures, like arthroscopy, we utilize those soft spots we talked about. How do the standard anterolateral and anteromedial portals relate to the bony structure?
Exactly. The anterolateral and anteromedial portals are specifically placed to exploit those thin, triangular soft spots just off the patellar tendon. The standard portals are usually placed about a centimeter above the joint line and maybe a centimeter lateral or medial to the edges of the patellar tendon. The trajectory must be carefully controlled, using triangulation and visual confirmation once inside to ensure instruments pass safely into the joint without scuffing the articular cartilage or inadvertently damaging the menisci during entry.
Okay, let's turn to the lateral approach. This is often used for complex fracture fixation, like tibial plateau fractures or accessing the posterolateral corner structures. What is the single, non-negotiable anatomical structure that dictates the safety margin here?
That would absolutely be the common fibular nerve, often still called the common peroneal nerve. It, of course, is intimately posterior to the tendon of the strong biceps femoris muscle as it heads towards the fibular neck. Therefore, any deep dissection in the lateral knee must proceed anterior to the biceps femoris tendon to absolutely protect this critical nerve. Injury causes foot drop. By incising the fascia lata in the interval between the iliotibial tract, which is anterior, and biceps femoris, which is posterior, the surgeon can expose the fibular collateral ligament and the posterolateral capsule while keeping the nerve safely retracted posteriorly out of harm's way.
Critical point. Finally, the risk profile for the medial approach, used extensively for tibial collateral ligament repair, medial meniscal access, or even some ACL procedures.
Wow.
What are the superficial hazards there?
In the medial approach, the immediate superficial hazard is the proximity of the saphenous nerve and the long saphenous vein. They are located running between the sartorius and gracilis muscles within the superficial fascia. The approach often requires dissecting just anterior to the sartorius muscle and then retracting the PS and serenus tendons, that's sartorius, gracilis, and semitendinosus, posteriorly. This deep exposure allows access to the tibial collateral ligament, TCL, where a capsulotomy can then be performed, either anterior or posterior to the ligament, depending on the goal. Careful retraction throughout is necessary to avoid traction injury to the saphenous nerve.
Okay, let's try to consolidate these into the definitive mastery points, a synthesis of the high-yield hazards and surgical tips that a professional absolutely must internalize.
Okay, let's recap the big ones. Firstly, the nerve risks. We've defined the major risks to the common fibular nerve, posterior to biceps femoris laterally, and the sensory infrapatellar branch of the saphenous nerve, medial parapatellar incision interiorly. We must also remember the posterior subcutaneous layer, which contains the short saphenous vein, the terminal branches of the posterior femoral cutaneous nerve, and the medial and lateral sural cutaneous nerves, all potentially vulnerable during posterior approaches, though less common.
What about the deep vascular structures, particularly those genicular arteries that are susceptible to damage during deeper dissection?
Right, deeply, we must be vigilant regarding the inferior genicular vessels. These arteries spiral around on either side of the proximal tibia, often traveling under the heads of the gastrocnemius muscle. Specifically, the inferior lateral genicular artery is at quite high risk if the surgeon attempts deep exposure of the proximal tibia inferior to the lateral meniscotibial ligament, maybe for fracture plating. Deep electrocautery or blind clamp placement in this area must be very precise.
And the danger of blind insertion during arthroscopy. What specific soft tissues are often damaged by poor portal technique or uncontrolled instrument passage?
Yeah, blind insertion is really a failure of technical precision and anatomical knowledge. It risks iatrogenic damage, surgeon-caused injury to critical stabilizing structures. This includes the articular cartilage itself, causing chondral damage, the menisci, leading to tears, the transverse ligament connecting the anterior horns, the meniscofemoral ligaments posteriorly, and even the sheath of the patellar ligament. Every portal insertion requires clear identification of the soft spot and controlled sequential entry, often confirmed with a spinal needle first.
And what is the major risk related to poor handling of the extensor mechanism, particularly the patella and its tendon, during total knee replacement exposure?
The risk of retraction injury is significant there. Excessive lateral retraction or eversion of the patella to expose the joint, or perhaps an overzealous release of the patellar ligament near its tibial insertion to gain mobility, risks iatrogenic damage to the entire extensor mechanism. If that mechanism is compromised, perhaps avulsed, repair is challenging and often leads to long-term problems like extensor lag and functional failure. It's hard to fix well. Similarly, a crucial safety tip for incision management is that extending a standard medial or lateral incision too far posteriorly risks inadvertently dividing the respective collateral ligament, the TCL medially or the FCL laterally, which constitutes a severe, complex iatrogenic injury. So we have, I think, thoroughly reviewed the core anatomical truths required for professional practice. From the rapid sequential development in utero that prioritizes the extensor system, through the biomechanical necessity of the minutiae confirmed by their mechanoreceptors, to the critical clinical significance of the deep attachment to the tibial collateral ligament right at the level of the meniscus. These relationships are key.
So what does this intensive deep dive mean for you, the listener? When studying complex joints like the knee, the true mastery lies not just in simple recognition or naming the parts, but in truly understanding the three-dimensional functional relationships and anticipating how these structures might fail under stress, or how they might be compromised during surgical intervention. We saw, for instance, that the patella, despite its prominence and the massive quadriceps tendon insertion, receives a significant portion of its blood supply via the richly innervated infrapatellar fat pad below it. It reminds us that even seemingly minor soft tissues often play a vital role in osteochondral viability and function. So here's a final provocative thought for you. Considering the inherently avascular nature of the central menisci, which drastically limits current surgical repair techniques, and reflecting on the very early fluid-based development of the joint cavity itself back at 52 days post-fertilization, how might future bioengineering techniques, perhaps using novel scaffolding delivered via the existing synovial fluid environment, or maybe targeted cellular delivery systems designed to mimic that early developmental stage, how might these be leveraged to successfully induce central meniscal repair, effectively bypassing the adult vascular limitation? That's the frontier. Go forth and explore that possibility.